Infertility is very common. It's more common than most people think, and it's not just a problem for women. 1 in 8 couples struggle with infertility, and to date, over 7.3 million have received infertility services. Last year, there were 1 million babies that were born from in vitro fertilization technology. The number of couples experiencing infertility is increasing. This is due in part to women having babies at an older age, but also due to other factors that we don't quite understand that are active areas of research at Northwestern. We define infertility as the inability to conceive or sustain a pregnancy after 12 months of trying in women who are under 35. For women that are over 35, we shorten that duration and we say that if they haven't conceived or sustained a pregnancy in 6 months, then they meet criteria for infertility. And people always ask, why the discrepancy? Why do we tell women who are older that the duration is shorter, and women who are younger, we make them wait a longer period of time? Some of that's insurance politics, and some of it is if you look at the time that it takes to conceive, most women will get pregnant within 6 months of attempting conception. In fact, 81% of all couples who are trying to conceive will get pregnant within 6 months. If you wait an additional 6 months to make that 1 year, you have about a 12% increase. But if you look incrementally, the first month that you try, the likelihood of getting pregnant is 38%. And so the question then becomes is, what do we gain by waiting another 6 months in order to classify somebody as infertile? When we look at the causes of infertility, I think the one thing that jumps off the page most for me is that 40% of all infertility is due to male factors. And again, many people assume that infertility is a women's issue. By and large, it is a women's issue, but it's also predominantly male-driven. When we look at the other etiologies of infertility, we break it down and we say that it can be a problem with the ovary, and about 20% of all infertility has to do with problems with the ovary. It can be a problem with the fallopian tubes or the uterus, and only in about 10% of cases is infertility truly unexplained, where we just don't have a reason. When we break it down further and we look at the causes of ovarian infertility, this can be further broken down. One of the most common categories is something called ovulatory infertility, where a woman does not release an egg every single month. And that can be due to a metabolic disorder called polycystic ovarian syndrome, which is an imbalance of hormones that leads to a woman not ovulating regularly and predictably. It can also be caused by stress. So the old adage of relax, you'll get pregnant. It's only partly true, but there is a little bit of truth to that. Stress can be in the form of psychological stress, or it can also be in the form of physical stress. So things like intense exercise, anorexia nervosa, can impact the reproductive system and prevent a woman from ovulating and therefore not getting pregnant. Diminished ovarian reserve is sort of the precursor to menopause. So menopause is the complete cessation of menses, and unfortunately, we see menopause or ovarian failure in young women. I have a patient who's 18 right now who doesn't have any ovarian function that's residual. We see this spectrum of diminished ovarian reserve often antecedent to the cessation of menses, and that period of diminished ovarian reserve is often one of the hardest things to treat. When we look on ultrasound, we make diagnoses both by history. We ask our patients lots of questions. We do laboratory evaluation, and we also do ultrasounds to look and see what the ovary looks like. I always joke that I can tell how fertile somebody is by looking at their ovary. And I wanted to highlight this picture. I also love to tell my patients that ovaries look like chocolate chip cookies. You want just the right amount. You don't want too many or too few. But in patients who have polycystic ovarian syndrome, oftentimes the ovary looks crowded by multiple follicles within it. Let's see if I can show you. So these are follicles within the ovary. This is the ovary, and on average, we want to see about 10 follicles per ovary. Anything over 12 is too many, and anything under 5 is too few. And this is the ovary of a patient of mine who's menopausal, and she just has one little follicle in the ovary. And then this is other pelvic pathology. This is a picture of an endometrioma and the presence of endometriosis, which I'm going to talk about in just a minute, but we can also diagnose that on ultrasound. When we look at pelvic factors, so things outside the ovary, inside the pelvis that may account for reasons for infertility, one of the most common is a blockage of the fallopian tubes. That can happen from previous sexually transmitted infections like chlamydia, and so it's really important that we counsel our younger patients to use protection for a multitude of reasons, but also for prevention of infertility. Other diseases in the body may impact the fallopian tubes, and one classic example is inflammatory bowel disease. Oftentimes we'll see patients who have Crohn's or ulcerative colitis who have some inflammation that surrounds the GI tract that can also impact the motility of the fallopian tubes. And then endometriosis, as I showed you previously, this is the presence of endometrial glands, or the inside tissue that's within the uterus that should stay on the inside of the uterus. That can travel to the outside of the uterus, and that can implant within the pelvic cavity. And that can cause a lot of problems associated with infertility. It can cause inflammation, it can cause tubal obstruction, and it can actually inhibit sperm from swimming all the way up the fallopian tube to meet the egg. Some diagnostic tests that we use to look at the fallopian tubes, this is an X-ray image called a hysterosalpingogram. And this is a normal uterine cavity. It has a really nice appearance to it. I guess I'm into food because I tell all my patients that their fallopian tube should look like angel hair pasta. And what we want to see is nice, thin fallopian tubes, and then we want to see the dye. We use an X-ray. We use X-ray and then dye that spills through the fallopian tubes into the pelvic cavity, and we want to make sure that that dye spills out. This is an abnormal hysterosalpingogram. So that's a pretty normal looking uterus. This is one part of the fallopian tube, and then the end of the fallopian tube is blocked, and so the fluid that we're pushing in doesn't have a place to spill out into the pelvis, and the fallopian tube becomes very dilated, and that's called a hydrosalpinx. And if there's no flow through the fallopian tube, fertilization won't be able to take place inside the body, and that's a common cause of infertility. This is a laparoscopy image. So laparoscopy is where we take a camera and we put it in through the belly button, and we're able to look at the entire pelvis. And this is the presence of endometrial tissue on the outside of the pelvis. So this is actually the front wall where the bladder is, and this is endometriosis implants all over the pelvic cavity. And then when we look at male factors, we look at the sperm as the primary method for analyzing male infertility. And when we do a semen analysis, this is a real image of what sperm look like underneath a microscope. And then to the right is a cartoon. We look at the volume, we look at the concentration, we look at how well the sperm are swimming. Are they swimming in a straight line, or are they zigzagging all over the place? And then we also look at something called morphology, or shape of the sperm. And we can learn a lot about the male by looking at the head, the body, and the tail of the sperm. And oftentimes we'll see abnormalities of that in men who are smokers. And it's just another argument for smoking cessation. It makes the sperm look abnormal. Abnormal sperm will not get in and will not fertilize eggs. Probably the most important factor is age. Women are having babies as we get older, and the issue with that is that age impacts fertility probably more so than any other factor that we face. Women are in their peak fertilities. Women are in their peak fertility in their 20s. So we are actually meant to have babies at age 22, which coincides for many of us with our medical training, our law school, our graduate school, and basically our peak career building years are often coincident with peak fertility. Fertility starts to decline by the age of 35, and while I hate this diagram, it really shows that sharp slope of fertility decline beginning at 35, and then it's a downhill battle after that. When we look at the likelihood of achieving pregnancy in 6 months, so for somebody who's 25, it's 80%. Most 25-year-olds will get pregnant. But what I think is a shocking statistic is at age 40, after 6 months of attempting conception, you're only 10% likely to have a baby. And so a lot of these Hollywood conceptions that we see happen with a lot of help. The average age of first childbirth in the US has changed dramatically. Back in 1980, that average age was 22, and it's moved up to 26. And while that may not seem like a huge shift, it happened in part because of all of these women in their 30s and 40s having babies. The single largest demographic increase for childbearing was in women ages 35 to 39. Having babies at an older age causes more issues with the eggs. So we talk a lot about, and we're going to spend a fair amount of time talking about chromosome abnormalities. Chromosome abnormalities can lead to infertility. So the egg is so chromosomally abnormal that it's unable to be fertilized by the sperm. It can be chromosomally abnormal to the point where it's fertilized by the sperm and it actually implants to become an embryo, but then stops growing and developing and causes a miscarriage. Or it can be chromosomally abnormal and it can survive outside, and issues such as Down syndrome are one example of chromosome abnormalities that are age-related in the majority of cases. So when we look at the incidence of chromosome abnormalities, it's really striking that at age 20, it's actually highly unlikely to have a chromosomal abnormality. It's 1 in 526. When we look at the likelihood at age 38, it's 4 times more common to have a chromosome abnormality from a 38-year-old egg than it is from a 20-year-old egg. And so women who choose to reproduce in their 30s have more trouble. They have more infertility, they have more miscarriage, and it often will take longer to achieve pregnancy. And so the question becomes is, once we make the diagnosis of infertility, what do we do about it? How do we treat it? And a lot of that really depends on the individual woman or the individual couple's issues. Certainly some issues like endometriosis are amenable to surgery, and we choose surgery as the first choice for endometriosis in many occasions, or fibroids. Ovulation induction, if somebody's just not ovulating regularly and predictably, we can give a pill. It's one of the few things that we can actually treat with a little magic pill, where we can help somebody to ovulate through the use of Clomid or letrozole, and it can be as simple as that. Intrauterine insemination is a little bit more complicated. It's where we take sperm from the male partner or from a sperm donor, we wash it, and then we place that sperm at the top of the uterus. And then in vitro fertilization is the most advanced fertility therapy that we have. And I think in order to really understand in vitro fertilization and what it is, you have to have an intimate understanding of how the normal menstrual cycle works. Basically, what we do with IVF is we take every step of the normal menstrual cycle and we alter it in some way to help a woman conceive. So in the normal menstrual cycle, it's controlled by the brain. The brain releases a hormone called FSH. FSH goes to the ovary and it looks at the entire pool of resting follicles that a woman has. And every month, every woman has a group of follicles within their ovary that they will use or they will lose. That FSH goes and it selects one follicle every month to become the dominant follicle. That dominant follicle grows, it produces the hormone estrogen, and then estrogen goes back up to the brain and says, hey, I have a follicle, ovulate me. And then the brain kicks out a hormone called LH, or the LH surge. That LH then goes to the ovary, it causes that follicle to collapse, and it causes the egg to go into the fallopian tube. That follicle then produces the hormone progesterone, and if sperm are present, sperm then swim up, they meet the egg inside the fallopian tube, hopefully fertilization happens, and the ovary produces progesterone in order to support fertilization. And then if fertilization happens, the embryo travels from inside the fallopian tube and it implants in the uterus. And that ovary produces progesterone to support an early pregnancy. So what do we do with IVF? We basically mess around with that entire process. So the first step of IVF is decreasing that hormone signal, that FSH signal. So as you recall, FSH goes, it looks at the entire supply of eggs within the ovary, and it picks just one egg to become the dominant follicle. When we do IVF, we don't want one egg. We want like 10 or 15 eggs. We want to pick the best egg to create the best embryo to have the healthiest baby. And so the brain, we turn off that FSH signal, and there are a lot of different tricks of the trade. We can use birth control pills, we can use estrogen, We can use something called a GnRH agonist or a GnRH antagonist that binds directly to the brain to prevent secretion of FSH. So the FSH that the brain produces is pulsatile, and it's that pulsatility that really picks that one follicle. So what we want to do is we want to overwhelm the ovary. So we want to give tons of FSH, but we don't want to give a gentle pulsatile signal because that'll get one egg. So we use exogenous FSH in the form of injections. And we have women give themselves injections every single day of FSH. And what that does is it goes to the ovary. It doesn't just pick one dominant follicle, but it takes the entire supply that that woman is capable of producing in a given month, and it grows each one of those follicles to become a dominant follicle. We then do a procedure called an egg retrieval, and this is done under anesthesia. We do this over in our IVF lab, which is over in Lavin, and using a transvaginal ultrasound probe that has a needle attached to it, we go through the vagina into the ovary, and we go into each and every one of those follicles, and we aspirate the follicular fluid, and we look underneath the microscope to find the egg within the follicular fluid. And we work closely with a team of embryologists who help to manage on the other side, on the laboratory side. They're finding the egg. They place the egg, or we place the follicular fluid into a test tube, and that's where IVF got the name test tube babies. So that fluid goes into a test tube. We then transfer that fluid into a petri dish. We look at it underneath the microscope, and then we take sperm, and we take the sperm and we fertilize those eggs in the laboratory. And so the big distinction between in vitro fertilization and any other type of fertility treatment is that rather than fertilization happening in the fallopian tube, it happens in the laboratory. I won't get into all the ethical issues associated with that, but that's where a lot of roots of religious opposition to IVF come in that fertilization is not happening inside the body. We then grow those embryos out for several days, and then we place 1 or 2 or 3 embryos back into the uterine cavity. But really, the goal of all of IVF is to find the single best embryo in order to maximize chances of having a singleton pregnancy. And so a lot of the innovations in technology that we're doing at Northwestern that I'm going to share with you have to do with embryo growth, embryo culture, embryo selection to find that one best embryo so that we can have one healthy baby at a time. So when we talk about those innovations, what are they? What do we do differently at Northwestern than the rest of the world is doing? So one thing that we're doing is we're growing embryos for an extended period of time in the laboratory. Going back to that image, we grow the embryos and we can put them back in either the day after fertilization, 3 days later, or 5 days later. And it's been shown in multiple studies that putting embryos in 5 days after retrieval, when they're at the blastocyst stage, has a higher likelihood of pregnancy. So these are 2 pictures of embryos. One is a cleavage, what we call a cleavage stage embryo, and this is 3 days after fertilization. It has anywhere from 6 to 10 cells called blastomeres, and each one of those cells has the potential to become any cell within a human body. When we grow that embryo out to day 5 or day 6, it's now called a blastocyst. It's highly expanded, and it's started to differentiate. So we can see the cells. We can actually pick apart the cells that are going to become the baby, and we can pick apart the cells that are going to become the placenta. And that becomes really important when we talk about genetic testing that we do on embryos. So this is a graph looking at pregnancy rates for patients who are transferred on day 5 versus patients that are transferred on day 3. So clearly the goal is to get the patients to grow the embryos in the lab so that we can pick the best embryo and transfer that single best embryo on day 5. One of the newest innovations that we have at Northwestern is something called time-lapse microscopy, or an embryoscope. And this technology is amazing. What it does is it takes a picture of every embryo that's growing in the laboratory every 5 minutes for the entire growth and development for 5 days. And so we get all of this data where we can see that embryo going from 1 cell to 2 cells to 4 cells to 200 cells at the time that it becomes a blastocyst. And those morphokinetic data, so the time that it takes to go from 1 cell to 2 cell or 2 cells to 4 cells, we use that data to help us select the best embryo for transfer. The other advantage of the embryoscope is that embryos don't like the air that you and I breathe. Think about that picture where the embryo is in the fallopian tube. That's a low oxygen tension environment, and we want to mimic that low oxygen tension. Embryos don't like room air that you and I breathe. The other phenomenal thing about the embryoscope is once you put that embryo inside the embryoscope, we don't touch it. We leave it in its incubator for 5 days, and we get all of the data that we need by looking at the images that the time-lapse microscopy generates. New technology is going to be such that we can look at it on our cell phones, we can be at home, and we can look at how our patients' embryos are growing and developing. We're not quite there yet, but that's the ultimate dream. When we do traditional, and Northwestern doesn't have any traditional incubators anymore. We've done away and we're 100% time-lapse, but when we used to do traditional incubators, you would have to take the embryo out of the incubator at all of these different points in time. And that's been shown to be really detrimental. So anytime you open and close the incubator door, you're causing changes in the pH of that embryo, and it's been shown that that decreases the likelihood to grow blastocysts. Remember the goal, we want to get one healthy, beautiful blastocyst, and that's best accomplished by using a closed system like a time-lapse monitoring system. So these are pictures that we use to help pick the best embryo for transfer. So on day 1, we start to see the 2 nuclei fuse. So this is what we call a 2-pronuclear embryo, and that has the DNA from the male and the DNA from the female starting to fuse. That DNA then fuses, and the embryo then undergoes its first cleavage division to become a 2-cell embryo. It then rapidly divides to become a 4-cell embryo by day 2, an 8-cell embryo by day 3. It starts to compact, you can't really see how many cells it has, and then it expands to form that gorgeous blastocyst that we talked about. I'm going to show you a video of, so this is time-lapse video, and you can see it's sped up, but that's syngamy. That's where we see the 2 pronuclei fusing. We just saw one of the first cell divisions, second cell division, third cell division. And then you're going to start to see things get a little bit more fuzzy. So that's the 4th division, just went to 8 cells. And then now that embryo starts rapidly dividing from 8 to 16 to 32, so on and so forth. The start of blastulation is where there's a cavity in the middle of that embryo that fills with fluid, and then it expands to become a blastocyst. And we look at each one of those time divisions from syngamy to first cell division to second cell division, and those have been correlated with better outcomes. So when we pick the embryos that divide at the points in time where they're supposed to divide, we get higher pregnancy rates. We also get lower miscarriage rates, and there's some data that shows that we have the ability, by looking at that embryo and seeing the time that it takes to make those cell divisions, which embryos are chromosomally normal and which embryos are going to be chromosomally abnormal. It's not a perfect system, but it helps. Again, so I can't overstate this. The goal is to have a single embryo transfer and to minimize the risk of twins. When we take 2 embryos and we put 2 embryos into the uterus, we often see twins. Full disclosure, these are my twins, wearing their Northwestern hats. So twins in IVF are very common. We actually are striving to decrease the overall likelihood of a twin gestation, but about 1 in 30 pregnancies is a twin pregnancy, and that rate has doubled tremendously. So between 1980 and 2013, we've seen an exponential growth in the number of twins worldwide. And the goal really is to halt that, to improve our technology to the point where we can have a single embryo transfer rather than a double embryo transfer. About 40% of all twins come from fertility treatment, but 64% are spontaneous. So not all twins that you see on the street are because of infertility. When we look at the IVF drivers of twins, about 16% of all infertility twins are from IVF, And 55% of those were from putting 2 embryos into the uterus rather than putting in 1. And 25% of all IVF live births are twins. When we look at the data, so this is actually Northwestern data that we pulled, and we look at the likelihood of pregnancy when we have really those beautiful blastocysts, what is the likelihood of pregnancy? And not surprising to any of us, but very surprising probably to most of you and to our patients, is if you put in just 1 blastocyst, the likelihood of achieving pregnancy is 51%. If you put in a second blastocyst, you would think mathematically, well, my likelihood's going to be 100. But it's not. It's only 56%. So there's an incremental 5 percentage point increase in the likelihood of achieving pregnancy. However, when we look at the likelihood of twins, you have a 6% twin rate from putting in 1 embryo, and that's because an embryo can split to become an identical twin. But 38% of pregnancies will be twins if you put in 2 embryos. And so at Northwestern, we have a mandated single embryo transfer policy for our good prognosis patients who are under 35, who have more than 1 beautiful blastocyst available. We simply just put in 1 embryo, and we've seen a tremendous decline in our twin rate here. So this is just graphically showing that increase in twins that I showed you on the previous growth. When we look across the board, IVF success rates all over the world has been increasing since 2004. It used to be that the likelihood of achieving pregnancy on a single cycle of IVF was 33%, and that's actually way better than in the original inception of IVF in 1978. 33% was pretty good, but now we're up to an average of 57% likelihood of success on a single cycle. That increase is really due to innovations in the IVF laboratory. So we talked a little bit about time-lapse microscopy, the benefit being twofold. 1, we get the data from looking at those cell divisions, and 2, we put the embryo and we don't allow it to breathe the air that we breathe. However, we do have to take those embryos in and out of the incubator. So the goal in the IVF lab is to make that air the purest and the best air that we can possibly breathe. So for those of us who are in the know, the cleanest air in all of Chicago is actually on the 24th floor of the lab and pavilion. It is so clean that you can make a microchip in our laboratory, and that requires the highest standard of air purity. So we know that contaminants to the air can cause lots of problems, and it's been shown specifically with an increase in VOCs or volatile organic compounds that beautiful blastocyst that we saw won't develop into a beautiful blastocyst if the VOC count is too high. So there are lots of different ways to filter air. You can do chemical air filtration, you can do UV light filtration, you can do inline filtration where you actually put air filters between the floors of the IVF laboratory, or many labs just use a portable air filtration system. VOCs are the most detrimental to blastocysts, and those come from construction, cleaning products, plastics, gases, lots of contaminants. Chicago air quality is actually a huge problem. So we don't mess around. This is our life air system, and it's a huge filtration system that is between the 23rd and the 24th floor of the lab and pavilion. And truly, we have the cleanest air in the city of Chicago. It's amazing. And that's Dr. Boulin, who's our chairman, really showing off our gorgeous air purifier system. So all of these things we do to increase the likelihood of IVF success. We use phenomenal air filtration systems, incubators that cost probably the same amount as the Northwestern tuition for 4 years. But the one thing that we can't overcome is age. And so IVF success rates decrease with age. And so what we're trying to do now is we're trying to push the technology a little bit further to see what we can do to increase that likelihood. Chromosomes are a big deal. So as we talked about earlier, we start to see more and more chromosome abnormalities as women get older. And we can't tell when we look at an embryo underneath a microscope, and even with time-lapse, we get more information, but we can't actually see the chromosome component of an embryo. When we look at aneuploidy, or the rate of chromosome abnormalities, for chromosomally normal embryos, those numbers just decrease with age, and chromosome abnormalities increase with age. And so We can do a lot of things. We can grow beautiful embryos, but we can't actually change the DNA, not yet. We can't actually change the DNA of those embryos. So what we can do, though, is we can test the embryo. We can look at all 23 pairs of chromosomes, and we have the ability to pick which embryo is chromosomally normal versus which embryo is chromosomally abnormal. And a lot of the chromosome abnormality is directly related to maternal age. So this is a karyotype. It's a metaphase spread of chromosomes, and as you can see, we have 23 pairs of chromosomes, so 22 chromosomes plus an X and a Y chromosome. And the important thing to understand when we talk about chromosomes and age is that as women get older, we have a decrease in the number of eggs. So I find it very depressing that we have the highest egg supply when we're fetuses. At 13 weeks of gestation, we have 6 to 7 million eggs. By the time we're born, that number is already decreased to 1 million. When we hit puberty, it's 300,000. And at the time of menopause, our egg supply is not depleted, but it's functionally depleted, and we're down to 1,000. So there's this rapid decline in oocyte number as we age. And along with that comes an increase in chromosome abnormalities. And the way that happens is we have something called a primordial germ cell in our ovary. So up until about 13 weeks of gestation, these germ cells are multiplying and they're creating more eggs. So they're undergoing a process called mitosis, where they are replicating and they are creating more eggs. But that halts at 13 weeks. So we have all of the eggs we're ever gonna have when we are a 13-week fetus. I find that really unfair. But what happens is because they've replicated so well, rather than having 23 chromosomes, these eggs have 46 chromosomes, just like us, just like humans. What we have to do, though, is we have to get that egg to have 23 chromosomes. The egg will contribute 23 chromosomes, the sperm will contribute 23 chromosomes, and those two will come together and merge to form an embryo that has 46 chromosomes. But what's really important is that the egg has to get rid of 23 of its chromosomes. So it has 46, and then at the time of ovulation, that egg has to kick out half of its chromosomes. And so the relationship between female age and infertility is that the older you are, the longer it takes you to ovulate, and the more mistakes are made in that egg. And so one of the most common chromosome abnormalities is Down syndrome, and that's because chromosome 21 is really tiny. And when that egg kicks out its extra chromosome at the time of ovulation, it kicks it out into a polar body, and chromosome 21 is really little, and it often gets left behind in the egg. And then the sperm comes in, and that contributes an additional copy of chromosome 21 to form 3 copies, or trisomy 21. And so aneuploidy, or chromosome abnormality, is the key to infertility, the key to understanding spontaneous abortion rates. And as you see, there's a very direct relationship between the number of aneuploid eggs, or chromosomally abnormal eggs, the likelihood of miscarriage, and the likelihood of live birth. So as women get older, we start to see increases in miscarriage rates and decreases in live birth rates. So like I said, fundamentally, we can't change the DNA of the egg. But what we can do is we can take that embryo, we can take a whole group of embryos, we can line them up, we can take cells out of the embryo, the cells that are destined to become the placenta, and we can test those for all 23 pairs of chromosomes. And then we have the ability to see whether or not that embryo is chromosomally normal or chromosomally abnormal. And that's been shown to greatly improve pregnancy outcomes, particularly in women who are over 37. So if you think of that fertility curve where you really start to fall off the curve, you can increase the likelihood of IVF success by finding a chromosomally normal embryo. Our goal is health. So there are 2 main components to DNA that we want to talk about. One is chromosomes, and then within each chromosome, we have genes, and genes are responsible for diseases. Not only do we have the ability to test for chromosome numbers, but we have the ability to screen for individual diseases. And so oftentimes what we do is something called carrier screening, where we screen a couple prior to conception to see whether or not they carry a specific disease. So we often will screen for things like Tay-Sachs, cystic fibrosis, Gaucher's disease, and we'll assess a woman's risk of having a chromosome abnormality or a genetic disease passed on to her child through genetic carrier screening. If a woman screens positive, we often will test the male partner. We always will test the male partner. And if both partners are both carriers for disease, then they have a 25% chance of passing on the affected disease to the infant. The things that we screen for are not trivial. And again, this is where some of the ethics comes into in vitro fertilization, but the diseases that we screen for cause babies to die. So they cause a shortened life expectancy. We don't screen for hair color, eye color, IQ. We don't really even screen for gender. So we screen for things that ultimately improve the health and the outcomes of the babies. And there are over 200 total disorders that we have the ability to screen for, and we have the ability to test the embryo for. And so I'm gonna spend a little bit more time talking about other things like fertility preservation. But to summarize with in vitro fertilization, the goal is really to transfer the single best embryo. We do that through improved culture conditions to grow that embryo to blastocyst stage. We use advanced air filtration systems. We have the ability to do pre-implantation genetic testing, either to test chromosomes or for the presence of disease to find the single best embryo. Another novel utilization of IVF technology, which is really exciting and innovative, is fertility preservation or oocyte vitrification. So back to this famous awful curve. And just for the record, when I was a resident at Northwestern, my mentors, who are now my partners, used to show me that I was right there on the curve. And then it was all downhill from there. So it's not uncommon for our residents to rotate through our service and then get pregnant. But the goal really, or the understanding, is that at 35, we start to see a huge drop-off in fertility. And so one of the novel things that we think about is, can we freeze our eggs? Can we go through an ovarian stimulation process? Can we take out our eggs at time of peak fertility? And can we return to use them at a different point in the future? So the thought process is, if you freeze your eggs at age 25 and you go back, if you have infertility at age 38, and you go back to use your eggs, you have the IVF success of a 28-year-old. Egg freezing has a lot of different indications. We do it very commonly for patients who have cancer. We have a huge oncofertility program at Northwestern. We do it for patients who are going to get chemotherapy for other systemic diseases that aren't cancer, like rheumatoid arthritis or sickle cell anemia. Women who carry a BRCA mutation often will need to have their ovaries out prematurely or will have diminished ovarian reserve, and so we recommend egg freezing in some of these women. Patients who have endometriosis who are at risk for future infertility. New indication, we're seeing a fair number of patients who are about to undergo gender reassignment surgery and want to freeze eggs prior to transition. Ethical options, not all patients want to fertilize all eggs at the time of an in vitro fertilization cycle, and so we can fertilize a limited number of eggs and then freeze the remaining. And then also elective, for those patients that are in medical school, residency, career, or just haven't met Mr. Right in their 20s, they now have the option to freeze eggs and use them later if they need it. So again, we worry a lot about age. It's probably the biggest challenge that I face on a day-to-day basis. We've already talked about how it's a decline in the quality and quantity of the eggs. We see decreased fecundability or decreased ability to get pregnant, increases in infertility, increases in miscarriage, and we also see some adverse effects of obstetric and perinatal outcomes. So IVF cannot overcome age. I think that's one of the big take-home messages of this talk. We can do many, many things to improve the likelihood, but that's the one barrier that we have yet to solve and overcome. This is a graph from the Society for Assisted Reproductive Technologies. It shows that IVF success, if you use a young, healthy 25-year-old, even if you use that egg when you are 47, you have the fertility success of a 25-year-old. So we have the ability to take an egg out of a 25-year-old egg donor, fertilize it, implant it into a 47-year-old woman, and she has the same likelihood of achieving pregnancy as somebody who's 25. That's Hollywood's secret, okay? For the rest of us, we see decline in fertility as women age. And a lot of the technologies that we do can back it up and increase success a little bit, but it's never going to be as high as a 20-something-year-old egg. The thought behind egg freezing is you take your own eggs. It's kind of like directed blood donation. Before you go in for surgery, you donate blood, you give that blood, that blood gets stored, and if you need it, we don't automatically transfuse you at the time of surgery, but if you need your blood, it's ready and it's waiting for you. Egg freezing, same idea. You go through ovarian stimulation. Remember, we give you lots of FSH, so we get lots of eggs to come out. We flash freeze those eggs through a process called vitrification, and we save those eggs if we need to use them later in life. So if you're 40 and you haven't yet tried to have a baby, or you're having infertility, by using your 25-year-old egg at age 40, you're going to have the same success as you would have at 25. There are two main methods of egg freezing. One is traditional slow freezing, and this is a slide that I borrowed from my old lab director at FCI, Jürgen Lieberman. And it is traditional slow freezing. It's kind of like the penguins marching into the water, whereas vitrification is the penguin jumping off the cliff and being rapidly plunged into liquid nitrogen. And this is just one of my favorite visual representations of the two methods of egg freezing. It has long been shown that vitrification is superior to slow freezing. At Northwestern, we do 100% vitrification. We don't slow freeze any of our eggs. Admittedly, it's technically a little bit more challenging and harder to learn, but we've put a lot of work into it and have really had some good outcomes with our vitrification technology. It's safe. I think that's probably the biggest take-home point, is that there have been extensive studies that have been done that have looked at infant outcomes after egg freezing and have shown no increases in things like congenital abnormalities. ASRM used to call egg freezing experimental, but in 2013, it lifted the experimental label from egg freezing, and it's now no longer considered to be experimental. It has become so mainstream, almost a little bit too mainstream, that tech companies have started to offer to freeze eggs for female employees. It's met with a lot of criticism in terms of what message are we sending, but political messages aside, I think it's a really good technology that in the right patient, in the right hands, it has some very powerful implications. It all started with Sheryl Sandberg allowing a female employee who had cancer, granting her the funds to undergo egg freezing, and that was met with backlash, like, what, you have to have cancer to preserve your fertility? And so it really sparked the question within the tech companies of, you shouldn't get special status, like all women should have that same opportunity. And so really a lot of the tech companies have taken the lead on egg freezing, and preliminary studies that have been done have actually showed higher retention rates for those employees of those companies because they feel much more supported from a work-life balance standpoint. Egg freezing has become quite mainstream. It's all over the place. And outcomes have really been shown to be as good as fresh outcomes. This looks at IVF success on the back end when those eggs have been fertilized. And we've also looked to see from those eggs that have become frozen, we've grown them into embryos, we've done pre-implantation genetic testing, and haven't noticed any increases in chromosome abnormalities between the eggs that have been fresh and the eggs that were frozen. We've also looked at that long term, like how long can we keep an egg? Because ideally, the whole implication of the technology is that you keep those eggs for more than 2 to 3 years. If somebody thinks that they're going to have a baby within the next 2 to 3 years, I'm not certain that they want to freeze their eggs. However, if we're talking about 5, 6, 10 years, then I think egg freezing is a really good idea. And so the studies have really shown that long-term outcomes are similar. When we think about how many eggs do we need, looking at women who are under the age of 35, we probably need to have about 12 eggs frozen to have 1 live birth. And for women who are over 35, that number becomes a lot higher. When you have 12 eggs and you're under 35, the likelihood of having a baby is equivalent to IVF success, about 50%. When you have women who are over 36, again, it's similar to the live birth rate per IVF cycle for that patient. So not as good of outcomes because we can't overcome the impact of age. So this is one last video before we wrap it up. Speaking of mainstream, Speaking of mainstream, this was a news segment that aired last year.
Young women are making a dramatic decision to preserve their fertility. Last year alone, 5,000 women had their eggs frozen so they could be used at a future date, perhaps even years from now.
In tonight's Health Watch, CBS 2's Marissa Bailey talks to a young Lake County woman who took matters into her own hands for the sake of her future as a mother.
I wanted to be married and have at least one kid by 30.
Stop the tape. Did you hear that?
I wanted to be married and have at least one kid by 30.
Tammy Green thought she knew exactly how she wanted her life to play out, but it just didn't work out that way.
I'm a teacher. I love kids, and I wish I could have them by now, and it just hasn't happened.
Single and pushing 34 years old, Tammy felt time was running out.
I never thought I would do this.
Tammy dug deep into her savings, spending thousands to stop the clock and freeze her eggs. Soon, she was taking hormone injections to stimulate ovulation.
I was nervous every night to give myself, I'd have to psych myself up for an hour and then give myself the shot.
But overall, though, the pain wasn't that bad.
No.
It was worth it.
Oh, it was so worth it, yeah. It's 2 weeks of some discomfort.
She went through 2 cycles, yielding 21 eggs, now stored in these tubes. Tammy's doctor, Feinberg, says just a few years ago, women came in to freeze their eggs due to a medical problem like cancer. Now, 90% come in by choice.
It really allows women to freeze their biological clock.
Dr. Feinberg says a woman's fertility drops dramatically around age 35, then again around age 40. Tammy's age made her the perfect candidate, even if she uses those eggs when she's much older.
Her likelihood of success is then going to be like that of a 34-year-old.
Using her frozen eggs in a round of in vitro fertilization will give Tammy about a 50 to 60% chance of getting pregnant. It doesn't always work, but the younger the egg, the better a woman's chances.
What I'd like to see is younger women, more women like Tammy, who have not yet experienced age-related declines in fertility.
Tammy says freezing her eggs makes her feel more in control of her life.
For you, the decision that you made almost empowered you.
Yeah, totally empowered me. It's not for sure. You're basically taking a gamble. But I feel like it's a better chance that I'll have kids doing that by not doing that.
She calls it peace of mind. Marissa Bailey, CBS 2 News.
Freezing process can cost up to $10,000. One round of in vitro fertilization is an additional $7,000 to $12,000. It's now thought that frozen eggs will last 10 years or perhaps even longer.
There's technology and innovation every day. Innovations continue to improve IVF success. Air quality is critical to maximize IVF success. Genetic testing can improve outcomes. And egg freezing may help to delay the timing of motherhood. Technology changes, but the goal remains the same: single healthy baby and healthy mother. Thank you.